I'm going to talk today about what kind of MS do you have and does it matter? If you have MS, raise your hand. If you know what kind of MS you have with certainty, keep your hand up. So there are a fair number of people who know their diagnosis, and when I'm done with this talk, you might not. So that is a picture of the Duomo in Milan, Italy, and Dr. Booley and I got to travel to ECTRIMS. This is the big European conference, and we got to present a poster when we were there. And the big topic in the last 2 years has been smoldering inflammation. So I'm going to talk a little bit about this and how this relates to what your diagnosis and subtype of MS is. Okay, so this is a big advertising push that one of the drug companies is putting out, which I think is very clever. You will see it. This is a big push in MS right now to introduce this concept. As much as I enjoyed the conference in Milan, my daughter happens to be studying abroad in Milan. And so we got to get together and see her. That's my wife and my daughter on the Canal region in Milan, where we had a lot of fun. But I'm not going to talk about that. This is what I'm going to talk about today. All right, so this is just an outline of what I'm going to talk about. I want to talk about the classic MS subtypes. And then I want to talk to you about the difference between acute and chronic or smoldering inflammation and what evidence that we have that this is going on in people with MS. There's radiologic evidence, there's clinical evidence. And then I want to talk about what our current treatments can and can't do and why we need new treatments to treat progressive MS. And at the end, I might talk a little bit about remyelination, and it gives me an opportunity to go over an analogy which is only half-baked, and I'm doing this mostly to irritate my colleagues who hate my analogies. And I'm going to show you some of the classic subtypes of MS, and these were developed based on clinical criteria alone. These go back 30 plus years. We have relapsing, remitting MS. I don't think we use the word remitting anymore because it doesn't really remit. You see it's punctuated by these acute attacks, and this is the most common diagnosis for people who are diagnosed with MS. There's secondary progressive MS, and this is used for people who had initial attacks and relapses, and then after a period of time, their symptoms gradually and steadily get worse. They had this subtype called progressive relapsing. This was to describe people who both progressed and had relapses, and now they actually call this active secondary progressive MS. And they have primary progressive MS, which are people who really don't have relapses. They just, from the very beginning, have slow, gradual progression of weakness and difficulty walking from the very beginning. These were the classic subtypes in MS, and they're very artificial in terms of how we divide them, and I think I'll illustrate why as we go on. If you look at the initial diagnosis, we see that about 85% of people are initially diagnosed with relapsing MS, and 15% have primary progressive MS. And if you look at what the natural history of relapsing MS is, there's this preclinical phase. You know, we occasionally will do MRIs on people for a concussion, or maybe they have migraines, and we find that they have abnormalities on their MRI that look, for all the world, just like what you would expect to see in MS, but they don't have any symptoms, and we call that radiologically isolated syndrome. You can already see the problem with defining things clinically here is if you have radiologically isolated syndrome where people don't have symptoms but they have MRI findings, well, how close are we looking at symptoms, right? For those people who had a little bit of fatigue, muscle aches, joint pain, and they actually did have symptoms early on, it's not so clinically silent. How often are people having new MRI lesions? Well, that depends on the kind of MRI you're doing and how good the MRIs are, right? If you go back 20 years, people didn't have as many MRI lesions. Now, if you use a 7 Tesla MRI, the really powerful magnet, you're going to see a lot more. The more that we look at these categories as time goes on, the more we find that they don't really apply. If you look at people who are not treated, the natural history of MS is that if you wait 10 years, about 50% of people are going to develop progressive MS. If you wait 25 years, 90% of people will have secondary progressive MS. Now, this is in the not treated population. If we take this pie diagram and say, okay, initial diagnosis, 85% of people have relapsing MS, what does it look like if you wait 25 years? It looks like this. It's not good. This is the reason that people have this view of MS as being a devastating illness. This is what happens to a population who are not treated. These statistics are accumulated at a time when our sensitivity for diagnosing MS was much less. This does not apply to people who are diagnosed today, but that's still how people think. Everything changed when we started using high efficacy treatments. And in fact, everything changed when we started using any treatment for MS. Every decade that has gone by, we see that the risk of developing progressive disease gets lower and lower. And so you are not guaranteed to get secondary progressive MS. And there are more and more papers that illustrate that early and high efficacy treatment does substantially reduce the risk of developing progressive MS. So we have these clinical trials with highly effective treatments, and it's like, oh, that's great. We treat people early, we're stopping relapses, we're stopping the MRI lesions, we've got this. Well, an interesting thing started happening about 5 years ago when we were going to these conferences. We were hearing about this concept called PIRA, progression independent of relapse activity. So they went back and they looked at the original clinical trials that were done for some of the high efficacy treatments. So this would be somebody who is not on treatment, and they have these relapses and then periods of stability between the relapses, and then later develop secondary progressive MS. Okay, so what happens if we put them on treatment? The expectation is we're going to stop them from having relapses and stop new MRI activity. And in fact, that does appear to be what happens. But the problem is when they looked at people's disability progression, they found that even though they stopped the relapses, there was still some progression in between the relapses, and they call this progression independent of relapse activity. And it seemed that, at least for some patients, the high efficacy treatment didn't address this. So what's going on? What's going on is that there are two separate biological processes that are going on simultaneously. So we know that there is acute inflammation, which is one biological process, and early on in the course of most people's MS, the acute inflammation predominates, and it's only later on that we see this chronic inflammation. The acute inflammation is what we think is responsible for causing the relapses and new MRI activity. It's the smoldering inflammation we think contributes to this slow general progression that causes secondary and primary progressive MS. And of course you have normal aging that's superimposed on that. And by the time you hit about the age of 50, that's when we say, oh, now you've got secondary progressive MS. And it's just because that's when things become visible. But the problem is the smoldering inflammation and gradual worsening is actually happening all the way through. And what I'm telling people, and they don't like to hear this, is that everybody potentially has progressive MS. Now, that's not true 100% for everybody, and it is to a very large extent substantially preventable by starting early and aggressive treatment. What kind of MS do you have? It depends on where you look on this diagram, right? So if you say, okay, I'm looking at the early part of this diagram, that's when people look like they have relapsing MS. If you shift it over to the other side, they look like they have secondary progressive MS, but it's really just one continuum. There are some people who just don't seem to have a lot of acute inflammation in the beginning. They just have more of the smoldering inflammation. We call that primary progressive MS. But it's not that simple. You have periods where you have a lot of acute inflammation. You have periods where you have smoldering inflammation, and you have periods where they go away. It does not mean you are destined to have relentless progression in a downward course. It means that there's some chronic inflammation and that varies over time, and there are periods where it's bad and periods where it's not so bad. The big problem is that our current medications just don't treat that very well. So this chronic smoldering inflammation, to understand what this is, I have to teach you about the immune system. So we know that there are at least two different immune systems that work in tandem with each other. You have this thing called an innate immune system, which almost all animals have, but we also have this adaptive immune system, which is a more advanced, highly specialized immune system. And they both have overlapping but different functions. Now, we used to think in MS, it was all about the T cell. Boy, were we wrong, because we know that treatments that exclusively affect B cells are actually extremely effective and some of the most effective treatments we have. So it is clearly not just a T-cell disease. So we thought, okay, it's still mostly a disease of the adaptive immune system. Actually, it involves the innate immune system and these cells called microglia, and they are largely responsible, we think, for that chronic smoldering inflammation. Your innate immune system is like your emergency response system, right? Just imagine if you had a city or town with no fire department and no police and no garbage trucks. Things would fall apart really quickly. If you have a problem with your innate immune system, these are the people who are immunocompromised and get sick really, really fast. Most of our medications for MS treat the adaptive immune system. The adaptive immune system are like this highly specialized, they learn, they're smart, they're very, very targeted. Sorry, I forgot, you all remember the slap, right? We can't have Will Smith up there anymore. So, my apologies. So, your adaptive immune system, highly specialized, and you don't need this, surprisingly, the same way you need your innate immune system. So most of our medications have an impact on the adaptive immune system, and surprisingly, you can wipe out B cells and you don't end up being that susceptible to infections. I mean, it makes a difference, but it's not like if you lose your innate immune system. So people are always worried about, well, if you take Ocrevus, Briumvi, Kesimpta, you wipe out my B cells, does that mean I'm going to be getting sick? And the answer is largely, only a little bit. It really doesn't make that much of a difference. Microglia turn out to be really important. So what are microglia? Microglia are resident cells in your central nervous system that are part of the immune system, and they're part of the innate immune system. And of course, it can't be simple. There've got to be at least two different types of microglia. There's M1 and M2 microglia, and they have different functions. And M1 microglia we think are like the bad guys in MS. They're the ones that are causing a lot of inflammation. We think those are the ones that are chewing up myelin. But M2 microglia are actually helpful. They're important for rebuilding myelin and for immune surveillance. So how do we know that there is smoldering inflammation? We can see it clinically because we know that people have progression of symptoms, and we see this in the clinic sometimes when we do the 9-hole peg test and the 25-foot timed walk, low contrast visual acuity. We see that in some people those numbers gradually get worse. We think that that's due to chronic inflammation, but we can also see it with specialized MRIs. There's ways now that we can visualize the microglia in chronic inflammation, and there are also serologic markers for it. If you look at people who have well-controlled MS, there are actually MRI lesions that are active. Even when you're on medication and you're not having new MRI lesions, some of the chronic lesions are active, and we call those chronic active lesions, and they fall into two basic categories: cells and pearls. Cells are slowly expanding lesions, and these are T2 bright spots which will gradually get bigger, and then there are these paramagnetic rim lesions, and these are MS lesions that at their periphery you can actually see these cells that are filled with iron, and we think that those are activated macrophages. About 40% of all MS lesions at any one time have some evidence for being chronically active. They're slowly expanding, or they have these paramagnetic rim lesions, which are less common, or they might have both. If you do a 7-Tesla MRI, this is an example of a slowly expanding lesion. And notice, it's not so easy to see. You have to zoom in on that one lesion and look at it over a period of years to notice that it's actually getting bigger. So a standard MRI doesn't typically pick this up. There's a way that we can tag inflammatory cells. On the left side of that image, this is what an acute lesion looks like. It's just filled with inflammatory cells. On the right side is a chronic lesion, and you see that in the middle, there's not a lot of inflammation, but those are labeled macrophages. And you can see that at the edge of that lesion, there are active microglia that are still nibbling away at the edge of that lesion. And again, we see this in about 40% of what appear to be stable MS lesions. Paramagnetic rim lesions, they're really hard to see on a standard MRI. Iron ends up being dark on that kind of sequence, and you can see on the left is what it actually looks like. On the right, they did an illustration because they're so hard to see. But we can find these in people, and it's an indication of chronic inflammation. There is yet another kind of chronic inflammation where you can see these things called lymphoid follicles. There are these collections of white blood cells that are in the meninges. They look like a cluster of B cells, and they don't belong there. And all of these things are evidence of chronic inflammation. And the problem is we know that to some degree, everybody with MS has some chronic inflammation and some of this smoldering inflammation. And that sounds bad, but we also know that not everybody gets progressive MS. Chronic inflammation and smoldering inflammation is not forever. If you have it now, it doesn't mean you have it tomorrow. A slowly expanding lesion does not expand forever. You can find they expand and then they stop expanding. And these paramagnetic rim lesions, the pearls, sometimes you see iron around the edge and then sometimes it goes away. It doesn't mean that this is just relentlessly progressive just because there's some chronic inflammation. Chronic doesn't mean forever. It does not mean that everybody is destined to get progressive MS. We've got a lot of different treatments. Dr. Booley and I use this sheet when we're talking about starting people or changing treatments. We've got a lot of different things. All of our disease-modifying therapies, though, have some limitations. And unfortunately, while they are extremely good at treating relapses and new MRI activity, they're not that good at treating chronic inflammation and slowing progression. And that may be because most of our medications do one specific thing. So to treat chronic inflammation, most of that is taking place in the brain. In fact, all of it is taking place in the brain, and the brain is protected by this thing called a blood-brain barrier, and that is a pretty impermeable wall that most things don't cross, and most of our medications don't get across that very well. And they also really target the adaptive immune system and have very little, if any, effect on the innate immune system. And this may be why our medications just don't do very much once people develop progressive MS. But there are these drugs called BTK inhibitors, and there's very good evidence that these do a good job of crossing the blood-brain barrier. And not only do they affect B cells primarily, but they also affect activated microglia. So they affect both the peripheral immune system and the central immune system and the innate and adaptive immune system. And we think that that is going to be crucial for being able to stop progressive MS. And in addition to that, there's this drug called frexalimab. And not only does that affect the central and peripheral adaptive and innate immune system, it affects B and T cells, whereas the BTK inhibitors mostly focus on B cells. So BTK inhibitors, bruton tyrosine kinase, and it is mostly expressed in hematopoietic cells. And it's really important for B cell activation. So BTK ends up being crucial for causing inflammation. And BTK is in microglia, and particularly in activated microglia. So if you can block the action of BTK, you may be able to affect chronic inflammation. The good thing about these BTK inhibitors is by blocking BTK, you're not killing the B cells or immune cells, you're just slowing their function. So it's not a cytotoxic treatment. You know, our current B cell therapies actually kill B lymphocytes. These do not, and they're reversible, and that might be important. And we know that BTK is overexpressed in people who have progressive disease. So there's a lot of evidence to suggest that BTK inhibitors should be effective for progressive disease, but as of yet, we still don't know exactly how much. And right now there are 5 BTK drugs that are in development: evobrutinib, tolobrutinib, fenebrutinib, remibrutinib, orelobrutinib. Do you guys get the system of what makes a BTK inhibitor? Brutinib. And what are the differences between these? There are differences in how they're dosed. Some are once a day, some are twice a day. Some of them are more reversible than others. And importantly, some are more selective. So when you give BTK inhibitors, there are other kinases, and some of them are more selective for just bruton tyrosine kinase. And presumably selectivity will mean less off-target side effects, right? So if you have something that's more specific, it's probably better. These are still being studied. I think the jury is still out. I mean, I'm very hopeful that these are going to be effective. And we've got a bunch of phase 3 trials for progressive MS, and these are the ones that I'm really excited about because this is the biggest unmet need that we have right now. It's anticipated that maybe sometime next year we're going to see the first BTKs be released for relapsing MS, and the progressive trials always take longer, and those are a little bit farther out. But we may have BTKs that people can take available as early as next year, at least I'm hopeful. Quickly about this drug, frexalimab, we're going to be participating in this trial. It is a monoclonal antibody, and it blocks something called the anti-CD40 ligand. CD40 ligand is something that's really important in activating inflammation throughout the immune system. And blocking it should have an impact both on acute inflammation and on chronic inflammation. And so, without going into too much detail, on paper, this looks like this could be a very effective medication. And there's going to be a phase 3 trial starting up for people with progressive MS that we're hopeful to get up and running soon. If I have time, I'm just very quickly going to talk a little bit about remyelination. And this is this half-baked analogy that I was talking about. When I think about remyelination and demyelination, I picture the central nervous system as a forest of trees, okay? And the bark on those trees is your myelin. Let's say these mushrooms are microglia, and they're doing their job, they're chewing up all the things that fall on the forest floor, but what we see in MS is that the microglia are starting to attack the myelin, and then this is what your forest looks like. So you have a lot of demyelinated neurons. Before we can have an effective remyelinating therapy, we have to be able to stop chronic inflammation, right? Because If you are trying to remyelinate when you still have inflammation, you're not going to get very far. The other problem is that just remyelinating is probably not enough to protect nerve cells that have been damaged early on. So if you look at the remyelination trials, unfortunately, most of them so far haven't made much progress. This drug clemistine, which is an over-the-counter antihistamine, actually did show effective remyelination, but it was very subtle. But there are some ongoing trials. There was a dimethyl fumarate remyelination trial in mice. Metformin, simvastatin has actually recently been looked at. Cladribine may have some impact on remyelination. Nanocrystalline gold, and now there's something called CAR T therapy. These are all in early studies and may be effective, but still nothing really out there yet. This clemistine trial was a small number of patients, and they looked at how much you could improve the conduction through the optic nerve by giving clemistine for 90 days, and it looked like it did actually make a difference, but it was a small difference. It increased nerve conduction in the optic nerve by 4 microseconds, which probably isn't clinically relevant. And just recently they published an article in that same group of patients. They did actually show some remyelination taking place in the corpus callosum by these very subtle radiologic measures. It's a proof that it actually did work, but how much did it work? Hard to know. And is it worth taking a triple dose of antihistamine? Well, I'm a little cautious about it because antihistamines have a lot of side effects, and what you might gain in remyelination, you might lose in all of the other side effects. So I don't generally recommend that people try this. What's that? That's a wrap. Is that right? That I just... Yeah, that's right. I finished my talk with a dad joke.